is a lower GI bleed. The upper GI bleed is not my topic. We will concentrate only on the lower GI bleed. So I would like to recall the anatomical knowledge regarding the lower GI bleed. There is a very important structure which is known as the ligament of treats, because this structure will will differentiate between the upper and the lower GI bleed. This structure is located at the fourth part of the duodenum. Distal to the this structure is bleeding, which is known as the lower GI bleed. I mean, usually you may think about that the lower GI bleed is maybe coming from the colon only, but it is not true. Lower GI bleed can be come from the small intestine like jejunum and the ileum, because this proximal to this structure, the bleeding which is known as the upper GI bleed, and distal to this, the bleeding which is known as the lower GI bleed. This is another slide which again shows you that these are the basic structures. This is anatomic cutoff of the upper GI is the ligament of Treats. It is located in the fourth portion of the duodenum. It connects the fourth portion of the duodenum to the diaphragm near the splenic flexure. So this is very important. You must know that distal to this ligament, the bleeding is known as a lower GI bleed. Okay. So there are basically two sources of lower GI bleed. Mostly more than 95% lower GI bleed is colonic origin, while less than 5% lower GI bleed is originate from the small intestine. Like in colonic bleed, we will discuss about the diverticular disease, which is usually occur in elderly male or females. The most common lower GI bleed causes are the anorectal disease, which is known as a hemorrhoid, anal fissure, fistula, and solitary rectal ulcer. Lower GI bleed can be caused by the lower GI malignancy, polyp, like ulcerated lesions. Lower GI bleed again uh, may become in the form of the inflammatory bowel disease, infected colitis. Angiodysplasia is a very rare cause of the lower GI bleed. This cause usually not the fresh bleed but the occurred lower GI bleed. Radiation colitis or proctitis. We will discuss all these types or the causes in detail one by one. So here a little bit know about the small intestine and causes of the lower GI bleed, like angiodysplasia, Crohn's disease, because Crohn's disease not only affect the large gut but also the small gut as well. So the infective infectious colitis is also called the lower GI bleed. Nucleus polyp ulcer lesion of the small intestine can cause the lower GI bleed. Radiation again cause the lower GI bleed. Macular diverticulum, a very common cause of bleeding in children. Aortoenteric fistula is a vascular anomaly in which the fistula is formed in between the aorta and the enteric, the small intestine. The mesenteric ischemia is again a cause of the lower GI bleed in elderly male with multiple comorbidities, especially cardiovascular system. So, as I told you, we will discuss about the anorectal disease. Anorectal diseases are basically four types. One is the hemorrhoid, which are again divided to two, internal hemorrhoid and the external hemorrhoid, depending upon their location. If it is located proximal to the dentate line, this is a dentate line. If it is located proximal to the dentate line, is known as the internal hemorrhoid. If it is located distal to the dentate line, which is known as the external hemorrhoid. And the three other causes of lower GI bleed, especially the anal fissure, anal fistula, and here is the anal abscess. Okay. Hemorrhoid. By definition, hemorrhoids are basically the cushion of submucosal tissue that containing the venule, arteriole, smooth muscle fiber, elastic connective tissue. In the left lateral position, when you examine the patient, you can find the hemorrhoids at 3 o'clock, 7 o'clock, at 11 o'clock. Why these hemorrhoids are formed? There are three conditions like obesity, constipation, and the pregnancy. All these three conditions causes the increased intra-abdominal pressure. Once the intra-abdominal pressure raised, that may lead to the hemorrhoids. As I told you, there are two types of internal hemorrhoid. One is the There are two types of hemorrhoid. One is internal hemorrhoid. Second is the external hemorrhoid. The internal hemorrhoid located proximal to the dentate line, while external is located distal to the dentate line. The both can present with the bleeding, but internal hemorrhoid usually present with painless bleed, while external hemorrhoid almost always present with painful bleeding. Internal hemorrhoid again divided into 4 degrees: first degree, second degree, third degree, and fourth degree. On the basis of prolapse, I will show you for your convenience. I have this diagrammatical presentation of this internal hemorrhoid. Look at this. This is the dentate line. Proximal to this is the hemorrhoid. In the first degree, patient usually complain the painless bleeding, no prolapse at all in the first degree. While in second degree, patient usually say something coming out of anus like prolapse that spontaneously reduce uh, with painless bleeding. While in third degree, they usually say something coming out of anus that need required finger or manual reduction. While in fourth degree, which is also known as the internal external hemorrhoid, in which patient have bleeding as well as prolapse which not reduce manually. So these are the 4 degree of the internal hemorrhoid. So the internal hemorrhoids, like in first degree and second degree, you can treat them with medical therapy like giving them the dietary fiber, stool softener, sits bath. There are options of rubber band ligation, infrared, photocoagulation, sclerotherapy. Same treatment you may give to your patient in the second degree. In third degree, may need the hemorrhoidectomy. But in case of the fourth degree, only operative hemorrhoidectomy is mandatory. So what are the hemorrhoidal treatment options? As I told you, there are two types of treatment. One is a minimally invasive treatment, which is a rubber band ligation, sclerotherapy, and infrared coagulation. While the second option is the surgical hemorrhoid. So for your understanding, I have a picture. Look at this. These are the three diagrams. One is the rubber band ligation. Second is the sclerotherapy. Third is the infrared coagulopathy. So this is, we are routinely doing this procedure in our endoscopy setup. If patient have the large internal hemorrhoid, we can place these rubber bands, which easily reduce the bleeding from hemorrhoid. And in case of the sclerotherapy, different sclerotherapeutic agent can be directly inject into the internal hemorrhoid. This is infrared sclerotherapy. Basically, infrared, we don't have this facility. This is a modern form of the coagulation in which the infrared beam is usually used. Excuse me. So again, little bit we must know about these things. That the rubber band is a very important and minimally invasive procedure which hardly take 5 minutes, and recovery time is less than 1 day. It doesn't require anesthesia and pain medication. Its success rate is more than 90%. In case of sclerotherapy, it requires 20-minute procedure time and its recovery is 2 to 3 days. It requires the pain medication, as in the same about the infrared coagulation, which actually take 20 minutes to complete the procedure, and recovery time is 3 to 5 days, and it requires pain medication, and its success is more than 75%. But the surgery has a good outcome. It has 98%, but it is a time consuming procedure. It requires the 1 hour procedure, and recovery time is 3 weeks. It required the general anesthesia and pen prescription as well. So this was all about the internal hemorrhoid. So what about the external hemorrhoid? These are the different pictures of external hemorrhoid. If you look at this is the 4 degree of internal hemorrhoid, which is again known as just like external hemorrhoid. This is the 4 degree prolapse hemorrhoid. This is the external hemorrhoid. This is the internal external hemorrhoid. This is thrombus external hemorrhoid. All these type of external hemorrhoid require surgical intervention or surgical hemorrhoidectomy. So the second Second disease, which is known as anal fissure. What is the anal fissure? Anal fissure is basically a tear in the lining of the anus. It usually can be seen at the level of 6 o'clock or 10 o'clock. It is a very painful condition. Usually patients come to you with the painful bleed and they have the severe pain, sensation of ripping, burning during defecation. So there are different causes and risk factor of the anal fissure. Usually anal fissure is caused by the trauma, by passage of the large, hard bowel or explosive diarrhea. There are less common causes of the anal fissure like foreign body insertion in psychiatric patient or the anal intercourse. Rarely anal fissure can caused by the Crohn's disease as well. The diagnosis of anal fissure is almost always on the history and the physical examination. On history, as I told you, these patients come to you with the painful bleeding and severe painful condition. And on examination, you can find it at 6 o'clock or 12 o'clock. In anal fissure, usually rectal examination endoscopy is avoided in early stage. When the diagnosis is unclear, then you may go for the sigmoidoscopy or colonoscopy to rule out the malignancy and the Crohn's disease as well. So anal fissure treatment, we have the medical and surgical treatment. The both treatment aim to reduce the tone of the internal sphincter muscle, leading to pain relief and just initial treatment is medical and aim to eliminate the constipation, eliminating the constipation, softening stool, reducing the anal sphincter. We have the treatment option of high fiber diet like fiber therapy, different laxative to soften the stool, and topical medicine like nifedipine and topical nitroglycerin can be used to reduce the pain and healing of the anal fissure. There is the option of botulinum toxin. The low dose of the botulinum toxin temporarily paralyzes the muscle for up to 3 months. It can be injected in the internal sphincter. If the medical treatment fails, then you have an option of surgery. You can refer your patient for the surgery that is known as the lateral internal sphincterotomy, which relaxes the internal anal sphincter by cutting this muscle. When we compare the medical treatment and the surgery has a high success rate as compared to the medical treatment. So the third type of disease of anorectal is fistula. Basically this disease is a surgical domain, but we must know because these patients may come to you with the hematochezia as well. As I told you, it is a surgical domain, need the surgical management depending upon the type and the site of the fistula. So the solitary rectal ulcer is the fourth anorectal disease and a common cause of the rectal bleed, especially in the male. The usual age is 48, but my experience that I have so many patients, females are more as compared to male, and the young teenagers are more having the solitary rectal ulcer. Its prevalence in general population 1 is to 1 lakh, and it usually present with the rectal bleed in 56% according to some study. These patients may come to you with straining, pelvic fullness, and mucus discharge, incontinence, tenesmus, and pain for less frequently. Endoscopically, these lesions may be maybe as ulcer or polyp, or this is just an endoscopic view, two different patients endoscopic picture. Here you can see a large deep wide base ulcer surrounded by severely erythematous mucosa. Usually these form an anterior wall of the rectum just within the 10 centimeter of the anal verge. And this is the endoscopic view. On histopathologically, it has a typical characteristic feature. So the treatment of this basically to direct the alleviating the symptom and interfering with some of the proposed etiology mechanism. It requires a conservative treatment like high fiber diet, lifestyle changes, exercise, physiotherapy, and high fiber diet, increase water intake and fruit and other things. There are certain pharmacological therapy for this disease like anti-inflammatory enemas and suppositories with limited success, but worth trying. If symptom persists, then you may send your patient for the surgical option because there are certain surgical intervention can be offered to the patient if he or she is not responding to the medical and conservative treatment. So the colitis. So I discussed about the anorectal disease, in which we discussed the hemorrhoids, anal fissure, fistula, abscess, or abscess. I didn't discuss the abscess, which is not needed. But now the second most common cause of the lower GI bleed is the colitis. There are three types of colitis. One is infective colitis, second inflammatory colitis, third is radiation colitis. The infective colitis, as name indicates, there are two types: amoebic colitis and pseudomembranous colitis or C deficit colitis. And we will discuss this is the pseudomembranous endoscopic picture of the pseudomembranous colitis. Here you can see a thick yellowish membrane circumferentially involving the rectal or sigmoid wall, surrounded by severely erythematous mucosa. These patients may present with the lower GI bleed along with the diarrhea. This pseudomembranous colitis usually occur in patients with immunocompromised stage, like uncontrolled diabetes, dialysis dependent patients, and transplant patients, or those who are on immunosuppressant. So these patients may come to you with lower GI bleed, with the diarrhea. They might have fever as well. This condition can be treated by giving the metronidazole. So amoebic colitis is less likely present with the lower GI bleed, because amoebic colitis involve the cecum as compared to the rectum, and these patients usually have the diarrhea as compared to the lower GI bleed. It can be again treated with the metronidazole. Or talking about the inflammatory colitis itself is a separate and a big topic. We will not go in the detail. We will just for your understanding, I have to tell you there are two types of inflammatory disease. One is the okay. One is the ulcerative colitis, second is the Crohn's disease. These are the certain endoscopic pictures. Ulcerative colitis is usually present with the lower GI bleed because it involves the rectum, while in Crohn's disease, this condition is less likely present the lower GI bleed, because rectum is spared in this condition. So this is the summarized form of the ulcerative colitis and the Crohn's disease. Here you can see that the Crohn's disease inflammation is patchy, while in ulcerative colitis the inflammation is uniform and continuously. Crohn's disease involves the whole GI tract from mouth to anus, but in case of ulcerative colitis, it usually involves the rectum and the large gut. Blood and mucus is not common in Crohn's disease. As I told you, the Crohn's disease usually is spared, rectum is spared in the Crohn's disease, but in case of the ulcerative colitis, it usually presents with the blood and the mucus, and while Crohn's disease may cause the nausea and vomiting, but ulcerative colitis not. Abdominal pain is more common in Crohn's disease as compared to the ulcerative colitis. Inflammation is transmural in case of the Crohn's disease as compared to the ulcerative colitis. Crohn's disease is a granulomatous disease, while ulcerative colitis is not granulomatous disease. Due to granulomatous disease, this can cause the fistula, structure, and fissure, while the fistula, fissure, and structure are not common in the ulcerative colitis. The ulcerative Crohn's disease is common in smoker, while the ulcerative colitis is associated with the non or the ex-smokers. Crohn's disease can be treated with steroid immunosuppressant medication, but 5-aminosalicylic is not usually as effective as in the ulcerative colitis. When we're talking about the surgical treatment, the surgery may not eliminate the disease, but surgery can be eliminate the disease if it is involving the whole colon. So this was all about the colitis. This is the endoscopic view of the radiation proctitis. Radiation proctitis is a special form of the lower GI bleed, in which patients usually have the previous history of abdominopelvic radiation therapy for prostatic tumor or for the ovarian tumor in case of the female. So they may present with the acute radiation proctitis or a chronic radiation proctitis. This condition well treated by using the argon plasma coagulation. Lower tract malignancy. Sorry, lower uh, lower GI tract malignancy. Again, this is a totally different topic and a separate need a separate lecture. But we must know that there are certain lower GI malignancies can cause the lower GI bleed, especially the anorectal malignancy, rectal malignancies. These nuclear growths are significant cause of lower GI bleed. It may present as a polyp, sessile polyp, ulcer, or the masses. The sloughing off of lesion may present as a lower GI bleed. So the lower GI bleed, if patient has altered bowel habit and having significant weight loss along with the PR bleed, you must think about lower GI malignancy. And this require proper evaluation, investigation, biopsy, staging of nucleus to be done for the either chemotherapy, for radiotherapy, or the oncotherapy. So we must know that the lower GI malignancies can present with lower GI bleed as well. So coming toward the polyps by definition, these any growth or the mass protruding from the mucous membrane into the lumen. Structurally, there are two types of the polyp. One is the peduncular polyp and the sessile polyp. On the management point of view, there are two types of polyp. One is the neoplastic polyp is the non-neoplastic polyp. This is the classification of polyps. There are 6 types of neoplastic polyps. We will not go into the detail of these polyps. We just go through and know that classification of polyps. The second form is the hematomatous polyp, the most common juvenile polyp, which is commonly found in children. While pure Jaeger polyp is a very rare but a common form of the lower GI bleed in intestinal origin, because the pure Jaeger syndrome polyps are found in the small intestine. Inflammatory polyp like ulcerative colitis or Crohn's disease may have the polyp, but these polyps are also known as the pseudo polyps and benign lymphoid polyps. Certain other polyps like hyperplastic polyps. So what is the aim of treatment? The aim of treatment to reduce the ongoing bleeding from the polyp, and second, send this tissue to the laboratory to confirm either it is a malignant type of polyp or non-malignant type of polyp. Look at this. This is an endoscopic view of a polyp. This is a small sessile polyp. Here, this is our polypectomy scenario. We can grasp this one by using the electrocoagulation. Then once you electrocoagulate, this is the post-polypectomy side. As we know that the polyp can cause the bleed. Polypectomy is the treatment of polyp, but this polypectomy is the two-way sword because of this condition, the post-polypectomy bleed. Look at this. As I told you, the polypectomy is the treatment of polyp, but post-polypectomy can be a nightmare for the gastroenterologist. Like post-polypectomy can occur immediately, just after the polypectomy, but these patients may come to you days to weeks after the polyp removal. The most common cause of the post-polypectomy bleed due to the large polyp size, like more than 2 centimeter. You are doing a polypectomy of a large polyp of more than 2 centimeter, a polyp with a thick stall, a polyp is found in the right colon. There are chances of the post-polypectomy bleed. If you look at this is the polyp and it is grasped after polypectomy. Here you can see even the 2 spurting vessel or 2 spurting sites. And how will you manage this one? The management of the post-polypectomy bleed is again a therapeutic form of the colonoscopy. Here you can see that there are different options like endoscopic clipping. These are the third clips that can be placed directly. Look at this. This is another clip. Here you can grasp the spurting vessel or spurting side with this clip, and you can use the thermal contact with or without diluted epinephrine. Sorry. This is about the post-polypectomy bleed. You must know that the polyp and post-polypectomy bleed about this. Diverticular hemorrhage. Diverticular hemorrhage is a rare form of the lower GI bleed, which usually occur in elders with multiple comorbid. Diverticular bleed is basically arterial, typically present painless hematochezia. Hematochezia means fresh fresh blood coming from the anus. And patient with the diverticular bleed are candidate for endoscopic treatment if active bleeding. And non-bleeding visible vessels and adherent clot is found at the colonoscopy. This is the endoscopic view of the diverticulum. This is a diverticulitis. It is a diverticulosis, diverticulitis, and diverticular bleed. These are the three endoscopic views. So how will you manage this one? So that if you can identify it, once you identify the bleeding site, then you can inject the diluted epinephrine by using the injector at the bleeding site, and you can use the endoscopic clips like this. This is all about the diverticular habit. The rare form of the lower GI bleed is angioectasia. Angioectasia, this is the angioectasia, are just starry shape, fresh oozing blood. It is a rare form of the lower GI bleed. It usually occurs in the right side of colon and elderly. The angioectasia usually present with focal blood, but sometimes it may present with the overt hematochezia. The identification of the angioectasia is a little bit difficult as compared to the other causes of the lower GI bleed. Again, it requires endoscopic hemostasis therapy if there is evidence of acute or chronic blood loss. There are two different treatment options, like one is the contact and the second is the non-contact thermal endoscopy. This is one of the form of the non-contact thermal therapy in which the ergon plasma coagulation can be used, and through this ergon plasma coagulation we can coagulate the bleeding point and stop the bleeding by doing this. So this was all about the different causes of the lower GI bleed. So now moving toward the approach. Now, as you have the background knowledge of the different causes of the lower GI bleed, like anorectal diseases, we discussed about colitis, we discussed about the polyp, we discussed about the malignancy, we discussed about the rare causes of lower GI bleed like diverticulosis and angioectasia. Now it's time to make your approach. The approach is very important. Starting from the basic. Again, for your approach should be toward the history is very important. Then do the physical examination and send certain laboratory tests. History is again important. As I told you, you must ask about the nature and duration of bleeding. You may ask about the painful bleeding or the painless bleeding. Is something coming out of the anus or not? When you are suspecting the hemorrhoid, you may ask about the painful or painless bleeding. If you may ask about the something coming out of anus or not something coming out of anus. If patient has a painful bleeding, then you may think about the anal fissure. If somebody has a hematochezia and pus discharge, then may think about the fistula. If you may ask about the abdominal pain and the diarrhea when you are suspecting the colitis. Colitis, as I told you, infective colitis almost always present with abdominal pain, diarrhea, fever, while inflammatory colitis not present with the fever. If you are suspecting the lower GI bleed with malignancy, you may ask about the ulcer bowel habit and the wet loss. If patient has significant wet loss and ulcer bowel habit, then you may think about the malignancy as well. Past medical history, again very important. You may ask about the prior GI bleeding events. You may ask about the abdominal and the vascular surgeries. You may ask about the peptic ulcer disease, because sometimes large peptic ulcer may have the profuse bleeding that may not cause the hematemesis but may cause the fresh lower GI bleed. You may ask about the previously treatment or previous history of inflammatory bowel disease. You may ask about the previous radiation therapy of abdominal pelvic radiation therapy for the prostate and prostate malignancy in case of the male, and ovarian tumor in case of the females. You may ask about it. And it is also important to assess the comorbidity, the importance of asking about the comorbid like cardiopulmonary, renal, hepatic diseases, because that may that because that may put the patient at high risk of poor outcome and alter the management approach. You may ask about the different medication. If somebody is taking the NSAID, if somebody is taking NSAID like aspirin, disperine, morphine, diclofenac, all these cause the upper GI bleed and large peptic ulcer that may have aggressive hematochezia as well. You may ask about the antiplatelet and anticoagulant that may cause the coagulation derangement. So physical examination. So after taking the history, you must do the physical examination. Physical. Okay. You may. You have to do the vital sign like doing the blood pressure, respiratory rate, saturation. And when you check the blood pressure, you must check the postural changes and see the postural drop. If somebody has a postural drop, it means he or she is in the hypovolemic state that need the uh, IV, enormous line, or ring elected. You have to examine the cardiopulmonary and abdomen, especially to rule out the abdominal tenderness and abdominal mass when you are suspecting the lower GI malignancy or the colitis. Then after doing this, you have to do the digital rectal examination. Digital rectal examination will confirm the anorectal disease like hemorrhoids, anal fissure, anal fistula, anal abscess, fistula and ano, and as well as anorectal malignancy, rectal malignancy. Even the polyps sometime can be palpate during the digital rectal examination. So after physical examination, you have to send certain laboratory tests like check the CBC, complete blood count, coagulation study, blood group in cross match, and serum electrolytes. uh, you have to keep the 2 to 3 minutes back cells in your hand, and then maybe need it before the procedure or before the endoscopy. So the second, what is the importance of the risk factor identification? Identification of the risk factor is important for poor outcome in the lower GI bleed. After identification, you may decide about the admission of the patient. The patient may need the ICU care, and after identification of these risk factors, you may say the family that patient have the benefit for colonoscopy after rapid bowel preparation. Patient with hemodynamic stability should receive the IV fluid. So, what are these risk factors? Uh, just a bit. These risk factor marker of the hemodynamic stability at presentation like tachycardia, hypotension, and syncope or ongoing bleeding has the poor risk factor, poor outcome of these risk factors are poor outcome. If patient is more than 60 and having the history of diverticulosis or angiotensin, again, are poor outcome for lower GI plate as well. How will you manage the coagulation defect? According to recommendation before endoscopy, you must check the PT and INR. INR is if it is more than 2.5, then you must transfuse the fresh frozen plasma. If patient's platelet is less than 50,000, then you have to transfuse the platelet before sending the patient for the colonoscopy. Now, what are the diagnostic and therapeutic modalities for lower GI bleed? Colonoscopy. I think you all of have been multiple times rotated in the endoscopy, and you all have seen the colonoscopy. Colonoscopy basically endoscopic modality which can through which we can examine the rectum, sigmoid, descending, transverse, ascending, and cecum, and as well as the last 10 to 15 centimeter of the terminal ileum. The colonoscopy is not only a diagnostic tool but also a therapeutic tool. As a diagnostic tool, it is recommended colonoscopy should be initial diagnostic procedure for nearly all the patient presented with acute lower GI bleeding. The colonic mucosa carefully inspected during the insertion and withdrawal of the colon. The main aim of colonoscopy to identify the bleeding site. The endoscopy should also intubate the terminal to rule out the proximal blood suggestive of small bowel lesion. So the aim of diagnostic tool to identify the bleeding point. Once you identify the bleeding point, then the therapeutic role of the colonoscopy is started. The goal of colonoscopy, you identified the bleeding site, and now you have to perform the hemostasis. The yield of colonoscopic diagnosis is only 48 to 90%. There are certain endoscopic options like injection, contact thermal therapy, non-contact thermal therapy through the scope clipping device, bend ligation. Like it is, this is the here you can see a ulcer with fresh oozing blood. We have the option of injection. Injection of diluted epinephrine as you can be used as a monotherapy or as a dual therapy. Like this epinephrine is diluted 1 is to 10,000, then injected. We can inject this epinephrine in all quadrant of the ulcer to achieve the hemostasis. If you fail to achieve the hemostasis, then you have an option of contact thermal therapy. Here we have the two probe. One is the silver probe and the second is the gold probe. We can use this in this way, which has the compress effect or to compress until sealing of the vessel. This is the diagrammatic how this contact thermal therapy can be used to achieve the hemostasis. We have the non-contact thermal therapy like argon plasma coagulation. Here the usually probe is not come in contact with the bleeding point. We have the probe through which we release certain sort of special sort of gas along with current, and then we can achieve the hemostasis. This therapy is useful in the radiation colitis in case of the angioectasia, and it can be used in the portal hypertensive gastropathy as well. This is so the fourth option, the through the scope clipping device and band ligation. I told you about the band ligation for the hemorrhoids, for treatment of the hemorrhoids or hemorrhoidal pain. We can use the rubber band, and we routinely do this procedure in our endoscopy setup. These are the certain clipping devices which can be used in case of the ulcer where the bleeding is not being stopped by injecting the epinephrine and utilizing the uh, other device that is known as the contact thermal device. So, as I told you, the colonoscopy has a yield of 48 to 90% of identifying the lower GI bleed. Suppose when, in spite of doing the colonoscopy, you cannot or we cannot find the bleeding site, then we have the other diagnostic modality. We have the two diagnostic modalities to identify the bleeding site, right? The radionuclide scanning and the mesenteric angiography. The radionuclide scanning is only a diagnostic modality which can detect a small amount of bleeding like the 0.05 to 0.1 ml per minute. How can we do the radionuclide scanning? Radionuclide scanning is a procedure in which a sample of patient blood is taken, and then the RBC of sample is labeled with the technetium 99, a special sort of the scintigraphy. Then after mixing this blood sample along with technetium 99, next the sample of blood is injected into the patient and the serial scintigraphy are taken. Like here you can see that it can be taken at the 5 minute, 10 minute, 50 and 20, 30 or 70 minute. Then you can identify the bleeding site. Then once you identify the bleeding site, then you can repeat the colonoscopy or send the patient for surgical intervention. The second modality is mesenteric angiography. Mesenteric angiography is a technique which you usually use by the interventional radiologist. So before mesenteric angiography, you must know the different blood supply of the large gut and role of the mesenteric artery. Here you can see the interventional radiologist usually assess the internal iliac artery, enter into the aorta and come in contact with the mesenteric artery. Once entered into the mesenteric artery, he usually use a certain special sort of angiographic agent and identify the bleeding site or the leakage site. Then this bleeding site can be therapeutic implication done by embolization of culprit vessel. So this is another modality which is the diagnostic as well as therapeutic. So once you just stop the lower GI bleed, and how will you prevent the recurrent of lower GI bleed? You have to advise your patient not to use the non-aspirin answer. But if somebody has the cardiovascular disease, they may use the aspirin as secondary prevention. But the aspirin cannot be used as a primary prevention of cardiovascular event. So it was all about the approach of the lower GI bleed. So it's time to summarize. I discussed with you the different causes. And its management. Like we discussed about the hemorrhoid, anorectal diseases, colitis, diverticulitis, angioectasia. And I told you how will you approach. You will start you will start your diagnosis by taking a good history. Good history almost always is very important, and then the examination, and then when you have to justify the certain lab test. to see and identify the risk factor. Then we discuss about the diagnostic and therapeutic role of the colonoscopy.